On QTV, we are back once again on a beautiful Sunday, quite hot here in Lusaka, and I should obviously think it is also hot even in other parts of the country, but hopefully that you're doing great, taking a lot of water, and of course trying to cover yourself with very light clothes, and on top of that trying to make use of various shades that we have. Otherwise, we are here once again, ladies and gentlemen, to discuss another issue of great concern that affects most of our children as well. And of course, this is TB. So today we're going to spend at least an hour discussing tuberculosis in children. And my guest on the program today is Dr. Monica Kapasa, who is a consultant pediatrician from Children's Hospital at UTH, and of course she's going to help us really understand what TB in children is, how children tend to be susceptible to TB, and of course how it's diagnosed, and other related information that you actually need to know about this particular program. Dr. Kapasa, welcome to our program. Good to have you today.
Good afternoon. Thank you, Nelson. I'm glad to be here, and good afternoon, viewers.
We're glad that you could make it despite your busy schedule. And of course, for your text messages, you can actually send them to the number that is scrolling on your screen there, which is 0955 5016, 0955 5016. You can send your questions, and Dr. Kapasa will be there just to respond and help you with anything that you would want to get your help from. Doctor, to begin with, what is TB?
So TB is an infectious disease that commonly affects the lungs, okay? And it affects the lungs, yes, commonly, but it can affect any other part of the body. It can affect the bones, it can affect the brain, it can affect the GIT, it can affect the heart. Okay, so it is caused by a bacteria called Mycobacterium tuberculosis.
Okay. Is the manifestation of TB in children same as it is in adults?
They have similar symptoms that they present both adults and children. So the common symptoms that you'd get that an adult would also have are things like a cough. And usually we are talking about a cough that is prolonged, going beyond 2 weeks. They present with things like fevers, they present with weight loss, they present with lack of playfulness. For children who are under 5, they will present with growth faltering. So you note that they are either not gaining weight as they should, or they are losing weight. They also present with things like night sweats, okay? So these are the typical presentations that you would get, that both adults and children would get. But there are also some atypical symptoms that you would get in children, especially when we're talking about very small children, infants who are less than 1 year. They would present with a cough even for as little as 2 to 3 days. Okay, so they'll come in with symptoms that are similar to severe pneumonia, where they've had a cough probably for 2 to 3 days. They have had a fever, they've had difficulties with breathing, they have chest indrawings. Okay, so for children who are small, even just a period of 2 to 3 days of a cough and problems with breathing may actually be TB. And then also you get a wheeze. Typically, a wheeze is associated with asthma. Okay. But children who have TB may present with a wheeze, and usually this is an asymmetrical wheeze, because you have lymph nodes that press on the trachea. Okay, so they press on the side of the trachea and so cause some partial obstruction, and they'll present with a wheeze. So if you've had a child who has been presenting with recurrent wheezes, you've given bronchodilators, they're not improving, you have to entertain that may be an atypical presentation of TB.
Now, in most cases, little children spend so much time with their mothers, and partly at least with their fathers as well. So one might wonder, how do they tend to get TB?
So TB is usually is airborne. Is airborne. So you would get it by inhaling the droplets. So what happens is, if you have a person, usually is an adult, who is around that child who's coughing, sometimes even just singing, or they may just have a flu and they are sneezing, as long as they produce those droplets, the child will inhale those droplets, and they will be because those droplets will contain the germs that cause TB, and so they will inhale it and it will affect them. So usually children will get TB from an adult who is close to them. Okay, so they would get it from an adult who has TB and is close with them.
In this case, how vulnerable are children to TB? Why are they so vulnerable?
So children are vulnerable to TB primarily because of their immunity. Okay, so children who are, particularly those who are less than 5 years, their immunity is not fully developed. So it's very easy for them to get an infection and they won't be able to fight off that infection. So they are prone to having TB primarily because of their immunity and the fact that they'll be exposed to an adult who may have TB. Sometimes you have children who may have other comorbidities, like they may be malnourished, and so that puts them at risk of having TB.
When we look at the TB in children and of course their immunity as well, is there a specific age that children become more susceptible to TB, or it can be throughout their growing up? Is there a specific age group?
So every one of us is prone to having TB. Okay, about 1/3 of us, we have inhaled the TB and we're probably living with the germ. What makes it present or become a disease is when our immunity becomes compromised. So like I've said, if a child, particularly those who are less than 5 years of age and those who are infants less than 1 year, are the ones that are most at risk of getting TB. So even older children, above 5 years, adolescents, they are all likely to get TB, but the most ones that are most vulnerable are those who are under 5 years of age. Yeah.
Interesting. In line with your work and also according to your experience working with children in as far as TB is concerned, how long does it take for a child to start showing symptoms of a TB after infection?
Okay, so the duration varies. Okay, so what you tend to get is if you inhale those droplets or those germs in the lungs, they are going to straight go to the lungs, and depending on the competence of the immunity, you are going to contain those germs. And so the fact that you've been exposed to those germs, you're going to have what we call latent TB, where you're not manifesting with the symptoms. So that varies depending on the immunity of the child. But smaller children, those who are less than 1 year, just the fact that they've inhaled immediately those germs, they can progress to having a primary infection right from the start. So the duration would depend on the age of the child and how the immune competent they are. So older children are likely to, like adults, contain the infection, and unless they become immunocompromised, they may present. So younger children, less than 1 year, as long as they've been exposed to somebody who have TB, they may present with TB immediately. But we have to understand that TB is very slow, causes a slow infection. So they may have the infection and it may not manifest for months or even close to 2 years. Yeah.
So in this case, how dangerous is TB in children, to say? Can it be fair to the point that a child dies?
Yes. TB kills if it's not treated. It's curable if you are diagnosed and you get treatment. But if you delay in treatment, about 60% of people who have TB may actually die. So it's very important that if a child presents with symptoms, meaning they have active TB, they are taken to a health facility and a health worker evaluates them and sees whether they actually have TB and starts them on treatment. So if it's diagnosed early, it's given the child is given treatment early, it's curable.
Are there any complications that come as a result of a child developing TB?
So yes, you can get, like I said, it's primarily a lung infection. Okay, but depending on the age of the child, the immunity of the child, they can have what we call disseminated TB. So they get extrapulmonary. It can go to any site. It can go to the brain. They may have TB meningitis. It can go to the heart. They may have TB pericarditis. Depending on how they are, they may go into heart failure. It can affect the spine. Okay, they get TB spine, and they have deformities of the spine. They have kyphosis, gibbous, and things like that. So yes, they can get complications if it's not identified early and not immediately treated.
What should be the reaction if at all a parent realizes that perhaps a child is having endless coughs and of course high body temperatures? What should be the reaction from a parent?
So it's important that if a child is presenting with the signs and symptoms that are suggestive of TB, they are taken to a health facility. Like I said, you get those typical symptoms of a child having coughing for more than 2 weeks. They're having fevers, they're losing weight, they're not active. They need to be taken to the clinic to be evaluated. And a lot of people feel that it is difficult to make a diagnosis of TB in children. So, there are lots of factors that you're going to look at. The symptomatology is one of the factors that you're going to consider if you're trying to make a diagnosis of a TB in a child. Okay, so the way they've presented, and then you have to look at contact. Have they had any contact? And when we're talking about contact, it's not just immediately, I've come today, you've brought a child who's been coughing, is there somebody in the house who's got TB just now? No. You have to look at 2 years back. So any contact of an adult who may have had TB in the past 2 years is significant. So you're looking at the symptomatology, you're looking at the contact as well, and then you're also going to look at the investigation, the examinations first of all, how that child has presented, what are you finding on physical examination of the child, and then you are going to go into the investigations for making a diagnosis of TB. So you are going to consider all these things, they are interconnected. So, the fact that the child has come with a cough for 2 weeks is not necessarily TB. You have to look at the other symptomatology and the contact, and then you go ahead and examine the child and look at the investigation and put all these things together for you to make a diagnosis of TB.
I'm glad that you've mentioned that, because in most cases, when any member of a family develops TB, most family members tend to start asking, why just a cold? I just a cold. So now imagine that a little kid as young as 5 develops TB, and at that particular point, there's no one in the family who's got TB.
Mm-hmm.
So there's all this kind of witch hunting that actually tends to come in. Others even go to an extent of thinking maybe the child might have actually been bewitched or something.
Mm-hmm.
So I'm glad that that point has actually been met.
Yes, so it's not necessarily in contact at that point. Was there anybody else, where this child has been, who has who's had TB? Sometimes it can be the neighbors. Sometimes it could be where you had gone to visit, somebody spent some time with that child and they were coughing, and they coughed out the germs, and the child inhaled those germs. Yeah, so we look at 2 years backwards, anybody who's had TB in the recent 2 years.
How is the diagnosis of TB in children done?
Okay, so like I've said, you're going to look at the symptoms, okay, all those symptoms that I've mentioned, and then you are looking at contact, obviously, and then you're looking at investigations. So in terms of investigations, there are quite a number of investigations that you can do to make a diagnosis of TB. The important one is that you need to have the sputum examined. Mm-hmm. And one of the challenges that is there, especially in making a diagnosis of TB in children, is because we are not able to get a sputum. But there are various methods that you can use to make a diagnosis, to get a sputum from that child, because it's very important that we know whether this child is having sputum positive or it's sputum negative TB, and the sensitivity of the drugs. So getting a sputum is very important in making a diagnosis of TB. But you can use other investigations as well. You can do a chest X-ray, to see, and depending on how the child has presented, if they have any lymph nodes, swellings, especially in the neck, you can get some fluids from there to take to the lab to be examined. If the child is presenting with signs and symptoms that suggest meningitis, you can get spinal fluid, cerebral spinal fluid, and you take it to the lab to be examined. Okay, so like I said, you're looking at a lot of things interconnected. You're looking at the symptoms, the physical examination of the child, the contact of the child, and the investigations. There are also some tests that you can do that would help to determine whether this child indeed has been exposed to somebody who's got TB. There's a skin test that can be done, and there's a blood test that can be done. So you have to put all these things in context as you are making a diagnosis of TB in a child.
All right, so ladies and gentlemen, that's the topic of our discussion today. We're looking at TB in children, and of course, in case you have any question, you can actually ask, and Dr. Kapasa will be there to respond to it, and of course provide that needed help. So the number is on your screen there, 0955 5016. That's the number, so you can come through, and of course you can share with us your experience, and of course your questions and all that. Let's come to treatment of TB. Is it the same as it done in adults?
Yes, it is similar. It's basically the same. So once you've made a diagnosis of TB, there are 4 drugs that are used in the treatment of TB. Probably what may be different is the site of the TB. That would determine how long you are going to give the medication to the child. But normally you'd give 4 drugs in the first two months, and then you drop 2 drugs and give 2 drugs for another 4 months. So in total you treat for a minimum of 6 months. Like I said, depends on the site. So that's for primarily lung TB that you treat for 6 months. If they have things like TB meningitis or TB of the spine, you may go on to treat for 12 months.
So why does that treatment take so long?
Yeah, because we have to make sure that the germs that cause TB are properly eradicated.
Is it that stubborn?
It is. It is very stubborn, yes. Okay, so the important thing to note is that, yes, as you start giving treatment to a child with TB, you note that they improve, and they do very well if you are giving the correct dosage of the medication. And within a few weeks, the child will start feeling better. They'll start playing. It's very important that as you are starting the medication, you caution the parents or the caregivers that even if a child feels better, they have to finish the whole duration, because people will feel that 6 months is too long to continue giving the child medication, and if they feel better. But it's very important, because what would happen is that if you stop the medication without finishing the whole course, these drugs these germs will start adapting, and they will lead to resistance. So if a child presents again with TB, the treatments that we are giving now may actually not be able to work for that child.
Okay, so when you obviously with HIV, we're always told that the virus multiplies as it gets into a human body.
Mm-hmm.
Is that also in the case of the bacteria with TB?
Yes, it does multiply, especially if you don't know that you have the germ. Okay, so that's why I said when you get it, it will come in the lungs. Depending on your immunity, it may stay there. But as it is there, it is multiplying. Okay, until, depending on your immunity, it eventually begins to cause symptoms. Yes.
I've come across, adults who have had TB before,
mm-hmm.
and during that particular treatment, you'd find that they usually display a number of, side effects of the drug. Exactly. I've just forgotten really the names of most of the drugs used, but you'd find that there is a drug that usually causes, joint pain. Sometimes, there is a change of color of urine.
Yes.
Sometimes others, even the skin, you'd find that they become darkish and all that. Exactly. Do those side effects also display in a child who is on treatment?
Yes. Okay, so because like I said, you get the drugs that we are using for treating TB in children are the same as the ones that are being used in adults. It's probably the dosing that's a little bit different, because we give medication based on the weight of the child. So these individual drugs, yes, have got side effects. Okay, and then it depends on the age of the child. Certain side effects may be there, but because the child is small, they may not be able to tell that these are the side effects that are. But there are common side effects that we tend to see, things like jaundice. I mean, yellowing of the eyes or the skin. They may get vomiting. They may get diarrhea. So you have to counsel the parents or the caregivers on the possible side effects. And then as you are reviewing the child, because what's going to happen is that you have to see that child regularly. So as you are reviewing the child, each time you're seeing the child, you're asking if there are any of those effects. And if they are severe, they would do some investigations to check on the severity of the damage to whatever organ is presenting, and see whether you need to reduce the dose or you need to stop and observe the child and start again. So yes, the side effects are similar in adults and in children, but depending on the age of the child, they may not be able to tell some of the side effects that they are having. But it's important that you explain to the caregivers or the parents the possible side effects that you would get on the medications that you are giving. And if they see them, they should bring the child back to the health facility.
After the treatment is done successfully, are there any chances that TB can reoccur?
Yes. The fact that a child has had TB once doesn't mean that they become immune for life. They can still present with TB at a later stage. Especially, like I said, children will get from an adult. So if they've had TB when they're at 1 year old, they are 5 years old. If there's another adult in the household who has TB, chances of them getting the TB again is there. And more especially so for the children that have HIV. Okay, they may have TB more than once. So yes, it is possible that even if you've had TB and it's been successfully treated, a child can still have TB in the future.
Interesting. Now, obviously, as somebody is on treatment of that nature, issues of nutrition, issues of dietary always come into play. Is there any special diet that a parent who is taking care of a child on a TB treatment needs to know?
Yes, I mean, like I said, one of the reasons that children are likely to have TB is if they are malnourished, or as they have TB because they are going to be inactive, they'll have poor appetite, they may not be eating so well, so they'll get malnourished. So it's important, yes, that they are given foods that are, first of all, balanced, that you would give for every other child. Adequate carbohydrates, protein, and fats in correct amounts. But more so for those children who are malnourished, we encourage that they are given foods that are rich in protein. Yes.
What happens if at all a child has lost appetite during that course of treatment? Are there any recommendations that you usually give to the mother or to any caregiver who is in charge?
So, poor appetite, yes, comes with the symptomatology of TB, and like any other child who's unwell, you do still encourage the parents to be giving, foods, especially those foods that they like. They are likely to take and retain them than forcing them any other foods. So we still encourage that they're giving them small portions of foods, and particularly those that they like. And as the child is getting treated, the appetite is likely to improve, and they can start giving them other foods that they'll be able to tolerate.
There are instances, doctor, that a child is on treatment and yet they are still coughing. Mm-hmm. There are times when a child could cough, and that cough perhaps could even result in vomiting after taking drugs. Mm-hmm. Exactly. Now, I understand that these drugs are usually given in dosages. What happens if a child vomits?
So if a child vomits, and if they vomit immediately, like within 30 minutes to an hour of having been given the medication, you need to repeat, because it means that that medication was not absorbed and it has come out. So it's very likely that treatment may not be adequate because the child is not getting the correct dosage. So if they vomit within an hour of having given the medication, you need to repeat. You need to give them another dose. If they are vomiting continuously, then you need to bring that child back to the hospital, because that will be an indication for a child being hospitalized. And if they are continuously vomiting, we have to find other ways of giving the medication, probably insert an NG tube until the vomiting stops and they're able to take the medication. Otherwise, there won't be any improvement if they keep vomiting the medication. So if they vomit once or twice, yes, you could repeat the medication. But if they are vomiting repeated times, then they will need to be taken back to the health facility, reassessed, and admitted if they need to be hospitalized for the medication.
All right, so you're still watching Ask the Pediatrician, and of course our topic of discussion today is TB in children. Your messages are coming through on 0955 5016, 0955 5016. Keep those messages coming. For now, we take a very short break. When we come back, we'll also want to look at the messages that are coming in, and of course look at now the management of TB, and of course how you can prevent your child from obviously getting TB and other issues surrounding TB. Stay tuned.
Beware the brilliance of new Harpic White and Shine. Its thick bleach and baking soda leaves your toilet blindingly bright and clean.
We love local. All of your favorite Zambian hits. And much more. Z Rampage, Fridays 9 to 12 on QFM.
On a long summer evening when the sun's hanging low, I'll be just waiting here for
Hello, Nam, Talu, Friday, Iliashi, me.
Hey guys, my name's El Mukuka. Catch me on Iliashi with Talu this Friday at 2 p.m. Done talking.
Oh God. Oh man. Hi, this is Janet. Catch me this Friday on Iliashi.
take my hand.
It's learning time and playtime. You know what they say. All work and no play makes Jack a dull boy. Join the adventure. Let's create, let's explore, let's grow, and let's discover. Tag along and join the coolest club, Q Club, every Mondays at 16:30.
Your favorite music video show. In terms of music videos, we have the latest, the most trending, the most happening.
Zilile, man. Remember, say I told you we're chilling with the prettiest and coolest girl on TV road. So stay glued to QTV, log on.
All right, so welcome back, ladies and gentlemen. To those who are just joining us, we are discussing tuberculosis in children. And of course, my guest today is Dr. Monica Kapasa, who is coming from UTH Children's Hospital, and she is a consultant pediatrician there. All right, helping us discuss how lethal TB is in children, and of course what you can do about it in case you are a parent, and of course you've noticed a few things about your children or your child, and of course these few things are leading to your conclusion that that child might have TB. Well, she's helping us really understand how can you know that perhaps your child has been exposed to TB. All right, so now, Dr. Kapasa, let's get to the messages. The first one really being quite funny there. Is it true that if the husband is on TB treatment and is having intercourse with his wife, the wife may have an endless coughing? It's coming through from Steve. I'll allow you to laugh.
Um, so, well, I mean, if the husband has TB, whoever is in close contact with them is likely to have TB. So, in terms of endless coughing, I would advise that the wife is also evaluated, okay, to see if they may have TB as well. Because of the close proximity, the close contact, it's possible that the wife may get TB from the husband as well.
Okay.
Yes.
Good afternoon. What is the best method of diagnosing the TB in children? Patrick from Kafir Gauge.
Patrick, so like I said, when you're diagnosing TB in children, you're looking at the symptoms that the child has presented with, the typical symptoms: coughing, fevers, weight loss, night sweats, poor appetite. And in addition, that child will need to be examined by a health worker. And there are certain things that are going to look for when they're examining. How is that child, the general condition of the child? Is the child wasted? Does the child have any lymph nodes? Is the child pale? They will need to listen to the lungs of the child. Will they get any crepitations? The abdomen of the child. So they will need to examine that child, and depending on what the healthcare worker is going to find, they will request to do some investigations. Okay, and so we have to put all these things together, including whether the child has been exposed to somebody, an adult particularly, who may have been coughing for a long time or may have TB. So we have to look at all these things together for us to make a diagnosis of TB in a child. Yes. And
in line with the same diagnosis, obviously for an adult, if I'm not mistaken, they're usually given some sort of, a bowl where they go home and maybe the following morning they bring sputum.
Yes.
Exactly.
Yes.
How about in a child? How is that sputum really taken?
So if it's a child who's older and they are able to cough, similar to an adult, you would advise that child to cough up sputum. But most times children who are less than 8 years old may not be able to cough out that sputum to put in a container for us to take to the lab. So there are various methods that we'll use. We'll use what we call a gastric aspirate, depending on the age of the child, where you pass a tube into the stomach of the child. Because what happens is that when a child coughs, because they are very small, they can't cough it out, they'll swallow it. So it will go into their stomach. So we'll pass a tube to try and see if we can get that sputum from the stomach for us to take to the lab. Another way is where we will induce sputum. Okay, so this entails a child being taken to a health facility. They'll be nebulized, with a gadget that we give to children who have asthma, with some fluids that will make that child produce sputum. And so when you are nebulizing, they're able to produce that sputum, and you'd be able to get, again with a tube, you'd be able to get that sputum and you send it to the lab. So those are some of the various methods that we use to get a sputum in a child who's not able to cough out like an adult.
Amber is asking, how true is it that everyone is born with TB?
So it is not true that everyone is born with TB. But if a mother who is pregnant has TB, it is possible for that mother to pass on the TB to her unborn baby. And so in that way, that baby is likely to be born with TB. But all things being equal, if that mother doesn't have TB at the time she's pregnant, it's very unlikely that, so it's not everybody who is born with TB, no. But we tend to be exposed to TB, in our lifetime. So no, it's not true that everyone is born with TB, but a pregnant woman who has TB can pass it on to the baby, and the baby is going to be born with TB.
Mr. Imano from Kasempa is asking, how cardinal is it for all to be evaluated for TB if one child in a home is diagnosed with TB? So maybe in line with this, I'd love to find out, Is it cardinal
Yes.
that everyone in the home should be evaluated for TB if at all one member or a child develops TB?
Yes. It is very important because we are going to use that child as an index case. Okay? So a child comes in and we have evaluated that child and we say, yes, this child has TB. What it implies that that child has gotten TB from somebody, particularly an adult in that household. So that child becomes an index for us to now evaluate the others, especially if there are other children there, and also to see whether there's an adult who actually has TB and they don't know but is passing on to the children. So yes, one person becomes an index case, and it becomes important that the other people in the household are evaluated.
My child is always having coughs and it lasts quite long. We stayed with someone who had TB 2 years ago. Could it be TB?
It is possible, especially that somebody had TB in the last 2 years who stayed with that child, and that child has been coughing for some time. So yes, it's important that that child is taken to a health facility, and like I've said, the child is evaluated and is investigated to see if that child has TB. There are other causes of chronic cough. Okay. So the fact that a child is coughing, all the time, and they have been evaluated and they don't have TB, we have to look at other causes of chronic cough in children. But yes, the fact that there's that adult who had TB and that child is coughing continuously for some time needs to be evaluated for TB. Yes.
Let's now involve another dimension in our discussion here, HIV, because in most cases there is a close link between TB and HIV. I don't know whether it's automatic that when someone or when a child has got HIV, then you expect them to have TB.
So TB and HIV are said to be cousins. Mm-hmm. So it is common for a child who has HIV to present with TB, and like I said, they may have TB more than once, but it's not every child who is HIV positive who is going to have TB. Most of the children we actually see who have TB are actually HIV negative. So yes, for a child who has HIV, it is possible that they can have TB because their immunity is compromised, and especially if they are not taking medications or they are not taking their medications well and their immunity is compromised, they are likely to have TB.
When a child is on antiretroviral therapy and they are also found with TB, can they continue the two treatments, and what happens?
So if, for example, a child is known to have HIV and has started on medication, and then subsequently they are found to have TB, yes, they can take both the HIV and their TB medication. What needs to happen is that the clinician will have to look at the type of HIV medication that they are taking, okay? And they may need to be adjusted because there are certain HIV drugs that have an interaction with the TB drugs. So once you start taking the TB drugs, you may lower the amount of the HIV medication, and so they may not be adequate in the system. So if a child is taking the HIV medication and they are found to have TB, they can take both medications, but the clinician will have to look at the types of HIV medication they are taking, and if it is found to interfere with the TB medication, they will have to change that type of HIV medication until the child completes the TB treatment. If a child has been found to probably have both at the same time, this child has been found to have TB and then subsequently that they are found to have HIV, what needs to happen is that the priority goes to treating the TB first. So they will not start the ART and the TB at the same time. They will start with the TB medication first, and then after 2 to 3 weeks, you introduce the HIV medication. So yes, they can take both medications at the same time.
we all know for sure that, you know, HIV really contributes so much to the suppression of the immune system of either an adult or a child.
Yes.
So what are the chances that, you know, we can eliminate TB in a person who is HIV positive? Because time and again, the immune system is always suppressed, is under suppression.
If they are taking their medications correctly,
Uh-huh.
their immunity should be improving. I mean, that's the reason we're giving the ART, is that we suppress the virus, and so the immunity improves. So there's no reason, you know, for the immunity to keep being suppressed if that person is taking medications well. So if they are taking the ARTs correctly, the correct type, dosage, the immunity should be able to improve. And so they shouldn't be presenting with TB if their immunity is improving on the ART, if they are taking the ART well.
As part of the routine checkups, there are some people that are so good at, you know, going for routine checkups. Whenever they just hear something biting, they could go and say, oh, okay, can you check my health? Is it okay for someone to go also for TB treatment checkup, even if they're okay, but just for the sake of just go and check?
For the sake of going to check.
Mm-hmm.
So like I said, 1/3 of the general population is living with latent TB. So in terms of checking, it entails, you know, doing the basic screening tests, and those may not be, you know, regularly available, and it may be costly. But if somebody, you know, begins to present with symptoms, then it would be nice. It would be encouraged to. They will be encouraged to go to the health facility so that they are evaluated if they have TB. So, just for the sake of checking for TB, if you are well and you don't have the symptomatology, I suppose it may not be feasible because of the fact that you need to be using some screening tests, and that costs money, I suppose, and they may not be readily available.
We come to prevention of TB.
Yes.
Exactly. How do we begin really preventing TB or protecting our children, especially if at all one family member has got a TB? How do we prevent it from, you know, spreading to other children?
Yeah. So it's important, first of all, that in the environment where we are living, we have adequate aeration, adequate ventilation. Okay, so that you know, there's a constant circulation of air, and it's important to educate the person who has TB on the cough etiquette, you know, so that they're just not coughing anyhow and producing these droplets that would go. So you would encourage them to cough away, you know, from the children, or, you know, they are coughing in their hands, or they have handkerchiefs or tissues that they are coughing in, so that they reduce the spread of the droplets. Yeah, and if an adult is coughing, and you take the children, obviously, if they are smaller children, they have to be evaluated. There's medication that can be given to prevent the children from getting TB from those adults, but they have to be evaluated to make sure that they don't have TB. If they do have TB, they have to be treated. But if they don't have, and they're living with an adult who has TB, then they can be given some medication to prevent them from having TB.
How about these children who are given the BCG?
Mm-hmm.
It's where we all know at least every child should have access to the BCG. Exactly. Once a child has been given that BCG, what are the chances that that child will develop or will be susceptible to TB?
So, what BCG does is that it protects the child from having severe forms of TB. So, it is possible that even if a child has been given BCG, they can still have TB in the future. What it protects against is the severe forms of TB. So yes, it's possible that even if a child has been given BCG, they can still get TB.
How about if the mother is, the victim of TB?
Mm-hmm.
What happens to the issues of breastfeeding? Can a mother who's got TB continue breastfeeding the child?
Yes. So a mother breastfeeding is not contraindicated in a woman or a mother who's breastfeeding. So even if the mother has TB, that child should continue breastfeeding. The only time the child will probably be stopped from breastfeeding is if that mother will need hospitalization, and so they will need to be separated. Otherwise, if the mother is well, there's no reason to separate the baby from the mother, but the baby will need to be protected. So again, the cough etiquette, the mask, but the baby should still continue breastfeeding.
My worry is because, there is so much contact that is there. There is a lot of proximity between a child and the mother, and there is that contact. So whether the mother is on treatment or something, but don't you think that contact that is there will always put the child at risk?
Yes, that child is at risk indeed. And the same preventive methods we've talked about, where there's adequate ventilation, and the baby will have to be evaluated, will have to be screened. If that baby is found not to have active TB, then that is a child who's going to benefit from being given medication to prevent the child from getting TB because of that close contact with the mother. Otherwise, if the child, the mother who is on TB medication and is breastfeeding, and the child has been evaluated and found to have TB, that child will need to be on medication. If they don't have active TB, then they'll benefit from getting the prophylactic medication because of the close contact with the mother.
So, doctor, what you're simply saying is every time that the mother goes for checkups, for review, the child also has to be reviewed, has to be assessed. Is that so?
Assessed, yes. So because, for example, if you have, I'll give an example of a newborn baby, and you have this mother who has TB, and you have evaluated and you have started them on medication. You have evaluated the child, and the child doesn't have any signs of active TB disease, and you're going to put that child on medication. So that child is going to take medication for 6 months, But after 3 months, it's encouraged that child goes back to be evaluated again. The investigation is done. But if they present with signs and symptoms of TB within that period, they can still be taken to be evaluated, and if they are found to have active TB, they'll be started on TB medication.
We go to Solwezi. Beauty has got a very interesting question here. She says, what can happen if the doctor is not really sure about TB? So there's not really being sure. So now my question would be, are there such circumstances where, doctors are not really sure that this is TB and they just put somebody on TB treatment? Because Beauty continues to say, then they even put you on medication. Later on, you decide to stop the medication. What comes to happen? So the question could be, are there such instances, doctor? Well, you're not really sure that this is TB, but you put somebody on TB medication.
Yeah, so again, it depends on where the child has been taken and what facilities that health facility or what equipment or investigations that health facility is able to do. So, like I said, you have to look at a lot of things together, as the symptomatology, how the child is behaving. If this child has been coughing, having fevers, losing weight, you have been giving antibiotics and they're not responding, and you are in an environment where you're not able to probably do a sputum to check whether that's TB, you are not able to do a chest x-ray that would help you to confirm that that's TB, you could treat empirically as TB and see whether that child is going to improve as you continue investigating that child, or you refer to a facility where they'll be able to do more investigations than where the child is. So there have been instances, yes, where because of challenges in making a diagnosis, you have empirically started a child on TB based on the symptomatology or the contact and you've given antibiotics and this child hasn't improved, and you strongly feel that it could be TB, children have been started empirically on TB treatment.
Are there any side effects, any repercussions?
So the side effects would be similar to the ones that you'd get when you're getting the medication. Not that it's going to harm the child anymore, no. So if by repercussions you mean that because the child doesn't have TB and they take medication, they will die or they will have big complications, no. Okay. They will have similar side effects to a child who's been diagnosed with TB, and they get the side effects of the medication. The only thing that may happen probably is that if it's not TB and you are giving TB medication, that child is not going to improve regardless. But if you find that you've given medication and the child improves, it's possible that it may be TB. If the child is not improving, then that child will need to be referred for other investigations to be done.
Obviously, my next area of concern now is when it comes to interaction between members with non-TB and a member who is on TB treatment or someone who's got TB. How is the interaction supposed to be done? What are the do's and don'ts that a family needs to observe if at all one member has got TB?
So, TB doesn't survive on surfaces. So, if you have TB and I give you a handshake, I'm not going to get TB by virtue of me, giving you a handshake, or we are eating shima together on the same plate and things like that. But if you cough or you talk or you sneeze, then people around you are likely to get TB. So we still need to look out and be wary of the fact that if somebody has TB and they are probably not on medication, they keep spreading it. Okay, so spreading it will be by virtue of the droplets, but not by virtue of me sitting with you and sharing, shima on a plate and things like that. No. So it is encouraged that if somebody has TB, they need to be on medication so that they protect the people that are around them.
So even when they are on medication, is the level of the movement or the activeness of the bacteria, is it the same even as before as compared to when somebody is not yet on treatment?
So, one of the things that happens that once you start getting the medications, you expect that bacteria will begin to be killed. It won't be killed instantly, but it will be eventually killed. So if somebody has, for example, what we call sputum positive, you check the sputum and it's positive, that person will have to have their sputum checked at intervals to see whether that bacteria is dying, okay, and the patient is improving. So yes, we need to be checking regularly whether the bacteria is dying by repeatedly checking the sputum. The challenge comes to those who have sputum negative, particularly the children. They tend to have sputum. You don't get the bacilla in the sputum, and so you will have to rely on the clinical improvement of that child. If the child came in with coughing, weight loss, fevers, as you start giving them the TB medication, you expect that that child is going to start gaining weight. The cough is going to start gradually reducing. The temperature will start gradually dropping. Okay, those will be the clinical signs that we're using in children who have sputum negative TB.
Well, Dr. Kapasa, thank you so much for taking time to come and help us really understand more on TB in children.
Thank you very much. Pleasure is mine.
All right, so ladies and gentlemen, I think that marks the end of our discussion today. To everybody who took part in and of course participated on the program today, thank you very much for your time. We had messages all across and I'm sure that you've been educated, but obviously if you missed some few points here and there, you can as well go to our YouTube channel, that is QTV Zambia, and of course you're going to find this episode as it will definitely be uploaded there. And on top of that, you can as well check other subsequent episodes that you might have missed that we have discussed. Remember, we have already covered covered malaria. We have already covered, diarrhea. We have already covered a series of other diseases that are common in children. But we still have others that are yet to be discussed. So make sure that you always make a date with us every Sunday between 13 and 14. My guest on the program today was Dr. Monica Kapasa, who came through from UTH at Children's Hospital. She is a consultant pediatrician and, of course, came to discuss TB in children. I've been your host, Nelson Zulu. Until next week, it's bye-bye.